I now invite Dr. Daniel Kao to share his screen. Dr. Kao will round out this session. He's an assistant professor of medicine at the University of Colorado and will be reviewing the latest and greatest in celiac disease as well as gluten sensitivity. Thank you, Dr. Kao.
Thanks for the introduction, and thanks to the organizers for all their hard work in putting this together, and all the attendees. This is really a great turnout this year. So I'll be talking about celiac disease and non-celiac gluten sensitivity. One second. Okay, so disclosure, and I have no relevant financial or non-financial relationships regarding this material. So learning objectives, I'll be talking about the spectrum of gluten-related GI disorders, and really this has evolved over the last few years to include, to kind of change the framework of gluten-related disorders to wheat-related disorders or these cereal-type disorders. Understanding key concepts to the management of celiac disease, differentiating celiac disease from non-celiac gluten sensitivity, and then recognizing the prevalence of non-celiac gluten sensitivity in patients with irritable bowel syndrome and unexplained dyspepsia. So I think this has become a very pervasive topic in society lately, where we see these this push for gluten-free products, and really a adoption of gluten-free products across a huge amount of the population. This is shown by a Gallup poll that was performed in 2015, where the question was asked to the participants of, do you actively try to include in your diet, actively try to avoid, or something you don't think about either way? And so this was regarding gluten-free foods. So of the 1,000 respondents, you can see that 21% actively try to include gluten-free foods in their diet. 58% don't think about it, and 17% actually actively try to avoid gluten-free products. So this is a really a remarkable number of people in this average slice of the American population who are including gluten-free foods. And this is despite the fact that the incidence or the prevalence of celiac disease in the population has not changed over the course of this time. So it remains at about 1%. So I want to start out by just kind of introducing gluten. What is it? I think there's a little bit of confusion about what it is. So gluten comes from the Latin for glue, and it's actually the protein component of certain cereals that provides the viscoelastic properties necessary to make bread. So it accounts for about 75% of the protein content of wheat, barley, and rye. And it's actually important for the providing energy source and the germination process of those seeds. Kneading modifies the interactions between these gluten proteins to give the elasticity, allowing it to rise and create baked products. The three primary grains that have gluten in them are wheat, rye, and barley, as well as hybrids of these grains. So looking at what are gluten-related, what's the spectrum of gluten-related disorders? So first on the left, we have celiac disease. This is really kind of of course, the classic gluten-related GI disorder, although it's really a much more of a systemic disorder. And time from exposure to symptoms is weeks to years. So this is really a chronic exposure to wheat that results in intestinal injury. This is clearly an autoimmune process that's got a very well-characterized mechanism. It's restricted to specific HLA genes, so DQ2 or DQ8 account for 97% of all celiac patients. It's notable for autoantibodies, enteropathy, and there are symptoms that include GI and non-GI symptoms. There are significant comorbidities, long-term complications, and this is really one of the key points in terms of why management of celiac disease is so important. We're moving over to gluten or wheat sensitivity in the middle column here. Time exposure of gluten to symptoms is much shorter here, hours to days. There's possibly an autoimmune component. There's pretty good evidence that there are increased intraepithelial lymphocytes in non-celiac gluten sensitivity. However, there's no association with HLA genotypes. We do not have great evidence for autoantibodies, so I'll talk about this briefly later on in the talk. We do not see enteropathy, but there are GI and non-GI symptoms. One of the key points here is that there are no recognized long-term complications of sensitivity in contrast to celiac disease. Finally, wheat allergy, I'm not going to spend any additional time on here, but wheat allergy is a pure IgE-mediated allergic response to wheat and components of wheat. It's a very quick reaction, minutes to hours, and as you can see, there's no enteropathy present. We don't identify autoantibodies. These are specific wheat-mediated antibodies, or wheat-specific antibodies. So this isn't meant to be a comprehensive review of celiac disease, but the AGA published a clinical practice update in 2019. So some of the topics here will really highlight some of these updates that have come out in the last year. So first of all, who should we be testing for celiac disease? So who to test and how to test and who to test. So starting out with who. So there was some discussion in the past about kind of what's the utility of broad universal screening for celiac disease. And there really is not currently support for this. And so we're really still talking about screening individuals who are at increased risk. And by doing so, we can increase the pretest probability and essentially reduce the number of false positive screens. So we're talking people who have typical symptoms. These can be either GI-related symptoms or extraintestinal symptoms, unexplained liver disease. We're going to think about people who have other autoimmune diseases, such as type 1 diabetes, autoimmune thyroid disease, Down syndrome, Turner syndrome. There's a huge association between celiac disease and autoimmunity in general. And then family history. So family history is of having a first-degree relative with celiac disease confers you a 10% risk for having celiac disease in an individual. So these are the patients that we should be screening. How should we be screening these patients? So still, the tissue transglutaminase, so TTG or TG2, is still the single best diagnostic test for celiac disease. It has excellent test characteristics as shown here. Sensitivity is around 93%, specificity is 96%. And so this is our go-to test. This should be done primarily with an IgA-based TTG, except for the case where there's IgA deficiency, which is a common immune deficiency, in which case we would look at IgG. The IgA endomysial antibody test is has the highest specificity of the celiac serologies. However, it's much more expensive. It's subjective because it's an immunofluorescence assay where they actually stain animal tissue with the patient's serum. And so it's not recommended as to be the primary screening test. So traditionally, if we're looking at a patient who has typical symptoms or is at risk for celiac disease, we're recommending performing serologies with the tissue transglutaminase antibody test, as well as duodenal biopsies to look for villous atrophy and intraepithelial lymphocytes. But there's a question that comes up is a biopsy always required to diagnose celiac disease? So there is a lack of consensus among guidelines here. However, emerged a acceptable pathway where if the tissue transglutaminase IgA is greater than 10 times the upper limit of normal in a symptomatic patient, you can consider repeating the serology and adding the endomysial antibody test to diagnose celiac disease if it's a patient who, for one reason or another, you would prefer not to biopsy the duodenum. And so this ends up having a very good high diagnostic accuracy, and it's something that you can consider. So this is a pathway you can see here. So the symptomatic group, still performing the tissue transglutaminase IgA antibody if this is positive. Then we can go down here if that value is greater than 10 times the upper limit of normal, and you can repeat the serologies and include the endomysial antibody, then we can arrive at the diagnosis of celiac disease. Otherwise, we're we're looking at if the tissue transglutaminase IgA is positive, but less than 10 times the upper limit of normal, or it's not an IgA, it's an IgA deficient patient, then we'd still recommend a biopsy before making the diagnosis of celiac disease. Just a reminder on how to biopsy. So biopsy the duodenum, even if it is visually normal, the sensitivity for atrophy or, of course, inflammation in the duodenum is fairly poor, just based on pure visual appearance. The recommendation per guidelines is to perform 4 biopsies in the second portion of the duodenum, and 2 biopsies in the duodenal bulb increases your diagnostic yield as well. Last, and I don't think this is probably something that a lot of us do routinely, is that it's recommended to perform a single biopsy per pass. And the purpose of this is to preserve the architecture as well as the orientation of the tissue to improve your diagnostic or your histologic evaluation. So in the diagnosis of celiac disease, what if serologies and biopsies are discordant? Meaning, what if you have a positive serology, but you're negative serology, but the biopsies show that there is villus atrophy and increased intraepithelial lymphocytes? So starting on the left here, one thing to remember is that in the presence of only increased intraepithelial lymphocytes, or a MARSH1 type of a histology, you really need to exclude other causes of this type of inflammation. So one of the big ones to remember is H. pylori associated gastroduodenitis. So this can cause intraepithelial lymphocytes to increase. And so rule out H. pylori in these types of patients. And then the other types of things to exclude here are really patient dependent. They can be medications, infections, specific conditions such as graft versus host disease. So if you have a negative serology but a positive histology, make sure you're thinking about other causes as well. The other more significant MARSH2 and MARSH3 type of histologic pictures have a different type of a differential diagnosis. And so again, consider these. One of these classic ones is also infection, graft versus host disease, inflammatory bowel disease. So what about positive serology but normal biopsies? So in this case, review what the initial histologic diagnosis was, or review the histology. These should be reviewed by expert pathologists familiar with grading kind of the Marsh classification for more subtle abnormalities, because a lot of times there are increased intraepithelial lymphocytes that can demonstrate celiac disease. The second is, was the patient on a gluten-free diet at the time of the biopsy? So consider repeating the biopsy after a 2 to 6 week gluten challenge in order to try to demonstrate that you have these histologies if this is a concern. And then the other consideration is you can classify a patient as a potential celiac disease, a person with potentially celiac disease, and this is done with HLA genotyping. So the only form of treatment is a gluten-free diet, and this is really a very sensitive. Patients are very sensitive to gluten. So there are approximately 3 to 4 grams of gluten in a slice of bread, and it takes only 50 milligrams of gluten per day to produce the injury related to celiac disease. Compliance is difficult. There are only about 30% of patients who are able to achieve a gluten-free diet with no intentional or inadvertent lapses that they recognize themselves. And so this kind of brings us to a question of what are the emerging therapies for celiac disease? Vaccination has been considered. So this NextVax-2, unfortunately, the phase 2 trial was stopped due to lack of efficacy compared to placebo. There's been a lot of investigation into probiotics, so bacterial strains that can help the digestion of gluten. There's an anti-IL-15 biologic type of a therapy that has been developed. Unfortunately, this also failed to demonstrate improvement in histology in a very refractory group of patients, so additional investigation is ongoing. And there are other approaches such as gluten-specific enzymes to decrease the gluten load, as well as to increase epithelial barrier. So how about for follow-up? So follow-up improves dietary adherence, but follow-up after diagnosis is often insufficient. So this is kind of a timeline for what types of follow-up we should be shooting for or aiming for. We should be assessing symptoms and serology at every visit, as well as remember to perform bone densitometry at the time of diagnosis and every 1 to 2 years thereafter. Serologies be used to predict mucosal healing in response to a gluten-free diet? So the answer is yes, this is still the recommendation. However, keep in mind that there was a 2017 meta-analysis of the diagnostic accuracy of serologies to predict persistent villus blunting in patients with celiac disease. And there is a fairly significant false negative rate. So there's not a recommendation at this time to perform repeat biopsies on a regular basis. Except for patients who have severe initial presentations, ongoing symptoms. But remember that serologies are not perfect in predicting ongoing response. So how about management of non-responsive celiac disease? So non-responsive celiac disease, first, review the initial diagnosis, review histology, serologies, HLA. Kind of the key point here is suspect that there's ongoing gluten exposure, review with the dietitian, support, and then look for potential comorbidities, so concurrent diagnoses that could provide an alternate explanation. For refractory celiac disease, in a patient who has no evidence of a concurrent diagnosis, we really go to immunophenotyping. I'm not going to spend too much time on this, but to be aware that there are 2 classifications of refractory celiac disease. Type 1 has a very good prognosis, 96% 5-year survival, versus type 2, who has really a very poor prognosis, 50% 5-year survival. The real risks here are ulcerative ginginitis, as well as enteropathy-associated T-cell lymphoma. And these should be referred to a specialty center. So kind of going back to other patients who don't have celiac disease, who still have gluten sensitivity, there's been a lot of investigation in terms of who are these patients. And one of these groups of patients are IBS patients. And so this was a study done in 2013, looking at IBS patients in whom celiac disease was excluded and were given a gluten-containing diet versus a gluten-free diet. You can see that in the gluten diet, symptoms became much worse compared to placebo diet. And so there's this idea that a significant number of our IBS patients, and I think we all recognize this in clinical populations, who have an improvement in their symptoms on a gluten-free diet. So this brings up the idea of non-celiac gluten or wheat sensitivity. These patients can have both GI symptoms as well as extraintestinal symptoms. A prominent one is fatigue or poor concentration. And so the diagnosis here is a little bit difficult. You have to exclude celiac disease, but there's no acceptable biomarker at this point. I wanted to briefly bring up these 2 studies that were recently published. So this was a study of patients with dyspepsia, and you can see that if you exclude all kind of organic causes that they looked at for dyspepsia, they have 43% of their patients remaining, and 35% of those remaining patients have a response to a gluten-free diet. So there's a good number of patients who will have a good response to a gluten-free diet. Whether those actually then respond to a gluten challenge is another question, and really isn't a feasible way to do this in normal clinical practice. But consider that there are a lot of patients who have a good response to a gluten-free diet in the absence of celiac disease. Looking at a recent Australian study of patients who have self-reported non-celiac wheat sensitivity, it's interesting that, kind of skipping down to the bottom here, the #1 symptom reported was bloating. However, the #1 reason for avoiding wheat that actually trumped the symptoms was general benefit to general health. So there are a lot of people who are avoiding wheat or feel that they're sensitive to wheat for reasons to improve their general health rather than for addressing GI symptoms. So the formal diagnosis of non-celiac gluten sensitivity, again, is cumbersome and it's not practical to be used because it involves a placebo-controlled, essentially gluten challenge. And so what we're looking for next is, are there biomarkers for a diagnosis of non-celiac gluten sensitivity? One of these potential biomarkers that's emerging is the anti-gluten IgG4. So this is in this study that was just published in gastroenterology, or is coming out in gastroenterology. In celiac disease, anti-gluten IgG class 1 and IgG class 3 were elevated. However, in non-celiac gluten sensitivity, IgG class 4 was elevated compared to control or celiac. So this might be a new emerging biomarker for non-celiac gluten sensitivity. Last topic here that I'll cover very briefly is that the reason there's been a lot of discussion of whether gluten is really the only culprit in wheat sensitivity. And this is why there's been an evolution of this condition from non-celiac gluten sensitivity to wheat sensitivity. So these cereals not only include a large amount of gluten, but they also include fructan, which is a FODMAP, and amylase trypsin inhibitors, which also are known to contribute to intestinal and extraintestinal symptoms. And this has been shown in a recent paper where there's a double-blind randomized controlled trial of patients on a gluten-free diet for at least 6 months. These were not patients who had either failed a gluten challenge or had but they had no evidence of celiac disease. And it turned out that when they were maintained on a gluten-free diet for a period of time, and they were given either a FODMAP bar, a gluten bar, or a placebo bar, and adding back the fructan was actually what induced the gastrointestinal symptoms. And so this is more evidence that it may not be the gluten, it may be more the FODMAPs that are in these grains that are contributing to symptoms. So with that, I'd like to thank you for your attention.
Great. Thank you so much, Dr. Kao.